Did you know that not all food allergies are mediated by immunoglobulin E, meaning those allergic antibodies that we as allergists can test for, skin testing, blood testing? Some food allergies, such as FPIES, is a different immune mechanism. FPIES is food protein induced enterocolitis syndrome. And today on the podcast, we are blessed to have world-renowned FPIES expert, Dr. Anna Nowak-Wegrzyn, on the episode to talk us through what exactly FPIES is, how it's diagnosed, how it's managed, and some really good news regarding this food allergy.
Welcome to Food Allergy and Your Kiddo with Dr. Alice Hoyt, the podcast about demystifying food allergies, diminishing allergy anxiety, and taking back control. Let's navigate this challenge together with evidence-based information, scientific research, and tried and proven practices. And now, here's your host, board-certified allergist and immunologist specializing in food allergy, Dr. Alice Hoyt.
Hello and welcome to the Food Allergy and Your Kiddo podcast. I am your host, Dr. Alice Hoyt. So excited to be joined today by world-renowned FPIES expert, Dr. Anna Nowak-Wegrzyn. Thank you so much, Dr. Nowak-Wegrzyn, for joining us today.
Thank you so much for having me. It's a great pleasure.
I want to really just dive right in here to talk about FPIES and for our food allergy mama and papa who's listening right now and their kiddo's been diagnosed with FPIES or perhaps someone they know has been diagnosed with FPIES. What really is FPIES and how do you sort of explain it to the families that you see?
Well, FPIES is a food allergy, that's for sure. And but it's a bit unusual food allergy, right? Like we are familiar with patients that have immediate reactions, anaphylaxis, hives, wheezing, coughing, etc., within minutes of eating the food. FPIES is a more delayed type of gastrointestinal food allergy, right? Like so symptoms are typically limited to the gastrointestinal tract with vomiting, sometimes diarrhea, but it's gastrointestinal, but if it's severe, it can be pretty scary because the child looks very pale and floppy and lethargic. And, so this vomiting is also accompanied by changes in the blood pressure, can be accompanied by changes in the blood pressure in severe reactions. So the symptoms start within 1 to 4 hours, typically 2 hours after eating the food, and can be very confusing, just because the child looks so unwell and there's no hives, there's no coughing, there's no rash, itching. So, allergy is not really on the mind of the physicians or the caregivers, but we know that there's a big category of non-IgE-mediated food allergies, right? So we have FPIES, we have proctocolitis, we have enteropathies. So this is well recognized. It's a farm food allergy. And as such, it also has a very favorable prognosis in general. Most children will outgrow it.
It's so
as they get
great.
older.
That's so great to hear. And I know a lot of our families are very happy to hear that. And I just want to interrupt you for 1 second and sort of camp on a point that you made about IgE-mediated versus non-IgE-mediated. Mm-hmm. A lot of times on the show, we'll talk about IgE-mediated, meaning a kiddo has an allergic antibody specifically to a food like peanut. And when peanut binds to that allergic antibody, it activates those allergy cells, those mast cells, to very promptly cause the kiddo to develop hives, swelling, trouble breathing. Vomiting can absolutely be a symptom of food allergy that a lot of people don't often recognize. But in non-IgE-mediated food allergy, we're not so much, or if at all, dealing with IgE. We're dealing with other immune mechanisms that cause what can be very scary reactions. Mm-hmm. And so I know that our families are happy to hear about the outgrowing part.
Mm-hmm. So, I think it's a really great point because, this delay, non-IgE-mediated food allergies are also referred to as cell-mediated food allergies. So the reason why there is a delay in the onset of symptoms is because those cells that encounter the food allergen, they are not mast cells, they are T cells or, other kinds of immune cells. They sort of get excited by this encounter and they start producing cytokines and other mediators, but it doesn't happen immediately. So we need this kind of a 2-hour time window for this to happen. And the vast majority of the children, it's called the non-IgE cell mediated because the vast majority of the children with those conditions, including FPIES, they have no evidence of positive allergy tests, right? Like our testing relies on detection of the food-specific immunoglobulin E or IgE. In FPIES, you don't see that, except for like a small subset of sort of so-called atypical FPIES who also have other allergic conditions. And, if they have eczema, there's more likely that you may have some low positive, like weakly positive allergy tests. But that's sort of, the majority are negative, even though they have repeated reactions.
And you and your colleagues talked a lot about that in the 2017 guidelines in the Journal of Allergy and Clinical Immunology for FPIES, and then also in an article in 2020 in Journal of Allergy, Clinical Immunology and Practice, talking about FPIES. And one of the points you guys also drive home is that how we really need more research in some of these areas, specifically about biomarkers, because as you mentioned, our traditional allergy testing, the skin prick or sometimes called scratch testing and the IgE testing does not detect or will not detect a classic FPIES case. It all comes back to that discussion that the family and the allergist have and the history that the allergist is able to really sit down and talk with families about.
You're absolutely correct. I mean, it's a clinical diagnosis like anaphylaxis, right? Like you don't have a test for anaphylaxis. You have to recognize the symptoms. You have to put it together and you're making the diagnosis on the spot. So and that's a big, huge problem that we don't have biomarkers, right? It's just really, we rely on the IgE testing to time the reintroduction of food for the, classic food allergy. We don't have that for FPIES. So we sort of go blindly and say, okay, it's been a year since you had a reaction. Why don't we try it again? Or if somebody had a really bad reaction, then say, let's wait a little bit longer. Let's give you, 2 or more years, sort of depending which food caused the reaction, right? Like if it's milk, we are more likely to try to reintroduce milk and dairy products sooner. If it's a sweet potato, maybe we can wait a little bit longer. It's not necessarily a staple food, for the nutrition. So, but it's a lot of, like this art of medicine that plays a huge role in FPIES. And we have to do challenges, if we want to confirm or refute or, the diagnosis, or if you evaluate for resolution, it's, there's nothing else. We have to try the food. So you eat the food and we see what happens.
Right. And I want to talk a little bit about oral food challenges when it comes to FPIES. But for our listeners, I want to take a second and talk a little bit more about early onset FPIES versus later onset, and then sort of grading the severity, mild to moderate. And also, of course, and this is probably going to go a little bit in the early versus late, but looking at what is acute FPIES versus chronic FPIES. And how do you sort of explain that to parents when a family comes in and says, my pediatrician thinks I have FPIES. Is this acute or chronic? I was reading this on Google. Help me out here.
Yeah. So I think that, we know that 90% of FPIES is acute, right? So I'll start from the second part of your question. So it's like all of the sort of collective experience, from centers that see patients with FPIES, about 10% will be like chronic, right? Like no. And there's some overlap. There's some patients and they have sort of both kind of symptoms. So the acute, is very dramatic. As I said, usually 2 hours after eating the food, the child starts vomiting and, has repetitive projectile, very forceful vomiting, and can be, this can be going on for hours. Up to bringing up bile, and frequently, if this reaction is more severe, there's lethargy, sort of, the child is weak and, sort of floppy and it looks
very
really
scary.
very
For an
scary. It looks
otherwise very
horrible,
healthy
right? Like a
kiddo.
very healthy child, right? But the good news is that this resolves within, a couple of hours or the next day. Maybe there's some diarrhea, but the next day the child is usually back to baseline, and the acute FPIES babies, usually, grow very well. They're big, robust babies, and they're perfectly fine in between the episodes. So there's no, chronic sort of complaints. About 10% are chronic FPIES, and chronic FPIES remains a little bit of much more of an enigma than the acute FPIES, because it's usually happens in like a really young infants. So the cases that I have encountered, the classic, chronic FPIES, are babies that are that are usually formula fed, although this may also happen in breastfed infants, that over time, over the course of weeks or days or, even a couple of months, they start developing symptoms of diarrhea, watery diarrhea. Sometimes there could be blood, sometimes not. And then the vomiting comes on, and the vomiting is sort of, is chronic, intermittent. It doesn't really have this, very clear cut association with the food ingestion. And it's just, but it's getting progressively worse. So those are the babies that are fed, formula, which is a high dose, right? Like it's a high dose of the food several times a day. And then, over time, they stop growing or they lose weight. So there's failure to thrive. And then at some point they get so bad that, they get dehydrated. They are admitted to the hospital. They need to be rescued with fluids, frequently admitted to the intensive care unit. So that's the classic chronic FPIES. That's what I see.
And typically that's either cow's milk or soy formulas
soy
that
formula
are triggering those.
Absolutely. So, the question is whether you could have chronic FPIES, like milder chronic FPIES with more intermittent, exposure to solid foods, and I think probably it's just not that we have really discovered it. So I guess we have to keep an open mind and consider things like that. But, if there's a child that, I'm sure Alice, that there's a huge potential for under and over diagnosis of FPIES just because of how nonspecific the symptoms are.
Right.
So I would say if you have a child that is getting those symptoms that are not escalating, sort of, according to this, what I described, like this, progressively worsening is just sort of intermittent. Or if this is a child that is getting older and all of a sudden cannot tolerate the foods they have been eating before, fine, it's very unlikely that this is FPIES, that this is chronic FPIES. I would say look for something else. Look for eosinophilic esophagitis, right, with like vomiting, full poor weight gain. Look at a very early onset inflammatory bowel disease. So just sort of keep an open mind. Don't label it FPIES. And then, of course, then we have to, as allergists, we have to sort of work along the gastroenterologist and decide, do we want to look inside? Do we want to consider other etiologies? But certainly, keep an open mind. And not everything that is like, unexplained is FPIES.
Right. And more and more families are able to gain access to hypoallergenic formulas. And I think more and more pediatricians are recommending that switch earlier than maybe 10, 15 years. How much do you think maybe we're missing? You commented on the over and under diagnosis of it. How much of it do you think that we're missing because we do have easier access to some of these formulas? What's sort of your thought on that?
I think you are absolutely correct. And I don't know, I couldn't put a number on it. I'm sure that, let me just back up a little bit. The studies that have been done in general population show that FPIES is being outgrown. Like the studies from Israel, from Korea, show that, kids can outgrow it within 6 months, within 12 months, very early. So I'm sure we're missing, we may be sort of, there may be much more FPIES, by the time we see those patients and, they were on this hypoallergenic formula and then now they're okay. Right. So For sure. I also feel that breastfeeding in general is protective, and I think we have higher breastfeeding rates than ever, right? Like there's more awareness, and more women are breastfeeding babies for a longer time. So generally the foods that are present in the maternal diet, generally, not always, it's not 100%, but generally, they are not as allergenic as the food that is fed directly. So this also sort of changes the expression of the disease. So yeah, I think that some of that sort of empirical treatment muddies the water. There are some patients that could potentially meet the criteria for FPIES, but they never express the phenotype.
And sometimes I know pediatricians they'll recognize symptoms, whether they think it's allergic proctocolitis or they are suspect that whatever it may be, something in the formula is upsetting the baby's gut, and they make the change. And then it might not be until around 1 year, when more foods are being introduced, that the kiddo does get referred to the allergist to sort of answer that question of, is it safe to introduce that food? And sort of along that line, I do want to touch a little bit on atypical FPIES before I ask you about oral food challenges. And atypical FPIES, meaning the kiddo does have IgE to the food, but the food clearly is inducing an FPIES clinical picture, not so much of the classic IgE-mediated picture. How often do you see that? I know the reports say that they're less likely to outgrow that, but what does that sort of look like in your clinical practice?
So, it really depends on the study, the population. I would say it ranges, and also on the food, because let's say our experience was mostly with cow's milk, which used to be the most common food allergen. And for milk, we saw up to like 25%, 20% of kids developing IgE. But I don't think this is as high for, let's say, oat or rice or, solid foods. So certainly, it's food dependent. Also, a study, but studies from Japan, for instance, report much higher rates of the, of the IgE. So it really, it's hard to put like a finger on it, how common it is. I would say, let's say 10%, like give or take. So 1 in 10 of kids with FPIES may have either initially or over the course of follow-up may develop IgE. I think those are mostly children that have eczema. And, why is it important? One, you pointed out that it seems that children that develop IgE have more prolonged FPIES. But, we've known this for years. We knew that the IgE-mediated food allergy is more longer lasting than non-IgE-mediated allergy, right? So once you have the IgE, it just means there's something special about your immune system, that if you get to the point that you produce IgE, that your immune system is really, really convinced that, we don't want that food. We're not going to tolerate it. But also that some kids, once they make a lot of the IgE, the vast majority of children with FPIES, even though they test positive, their symptoms are FPIES. So there's no rash, no hives, nothing. But if this is once in a blue moon, we have a patient that is overall a very allergic patient. They have wheezing, they have atopic dermatitis. They started as FPIES, but over time, now there are 3, and they have, over time developed those additional sort of allergic comorbidities. This is the child that when you are going to try the food, you're going to test them again. And when you try the food, you're going to do it, I call it a hybrid model, that you're going to feed them slower, because you're going to make sure that you don't want to give them a lot of food and then deal with like anaphylactic reaction. So you're going to wait 15, 20 minutes between each dose. But then you are going to watch them for 4 hours, after you finish eating, so that you don't send them home with FPIES,
Right. And when you're talking about trying the food, you're talking about the oral food challenge in the clinic in with the allergist. And that brings me to my question about the oral food challenges of how often do you recommend allergists to have the kiddo have an IV already in place? The reason to have an IV in place would be in case the kiddo does have a pretty robust positive challenge, meaning they do have symptoms, and we need to fluid resuscitate them, meaning get IV fluids into them to get them feeling better sooner. How do you sort of decide when to have the IV in place, or when you can sort of wait on that? Because we all know trying to put an IV in a kiddo is it just ups the angst.
Oh, yeah.
It the kiddos don't like it, the parents don't like, we don't like it.
Oh, yeah. And then, if you tried 5 times and you finally got this IV, the child is so upset they're absolutely not going to try the food. And there's like big fiasco. No, I mean, it's an excellent question, but honestly, I don't have a good answer. There's no consensus. And so far, we haven't really formulated what are the, conditions where you can do a challenge without the IV. My feeling is that a child that almost ended up admitted to the hospital, was admitted to the ICU, or the child that wasn't admitted, but developed really classic symptoms when they ate a tiny amount of food, then I would say, I'm sorry, we just have to do it, because then, if you have a child that is reacting, it's so much more difficult to put an IV. But it always is a discussion with the parents, right? It's always a sort of shared decision. Now, when you go to mild symptoms, I think, that's where we sort of hesitate. And, mild symptoms meaning, the child ate a serving, ate a full serving, right? And they developed 3 episodes of vomiting and they recovered at home. So, then I think you could argue that, a year later, there's a pretty good chance that they might have already outgrown it. Or even if they have a reaction, you can, manage it with, oral rehydration or Zofran, ondansetron, just to try to help them through it. And, but that, that sort of brings up another point, is that even if you don't put an IV and you want to do this, you have to have an office set up that allows for a prolonged observation, and it's not every office that can do it, how crazy the offices are, you have patients scheduled and, one after another, stuff like that. So, so you have to give it a thought, how to do it. So it's in a controlled environment, even though you don't have the IV, and then you would have the backup plan, what to do, and have the sort of agreement from the parents that they, understand that there's always a possibility that you would have to transfer that patient, to the emergency room
with any challenge, right?
Right.
When do you advise families who you diagnose with FPIES? When do you advise them, if you have an axial ingestion, when do they go to the ER versus when can they try to oral rehydration, breastfeed? Do you prescribe Zofran regularly to some of these little babies? What's sort of your approach?
So, so my approach is to, again, if there's some situations, in those patients that I said that really had dramatic past reactions, that I think it should be non-negotiable. You go. If they ate the food or they're having symptoms, even before they started having symptoms, I would go just to be close by, so you can get the intervention. But you should still, as you're going, right, you should be trying to rehydrate. So you wait 15 minutes, you try to give them clears or breastfeeding. Ondansetron is an antiemetic, so Zofran is an antiemetic. I do utilize it. I think that it's really low risk, of using it. We know that it's not 100% effective. So the more severe symptoms, the less likely that oral Zofran is going to stop the reaction. And they may need, then in the ER, they can give it IV, they can give it IM, they're giving fluids, etc. So that's one thing. And the other situation I would say, go to the emergency room would be, a child that keeps vomiting for hours and it's unable to hold anything, or if the child from the beginning, even though they don't have a history of severe symptoms, but from the beginning, they look really unwell. You cannot arouse them. They are gray and, like floppy, and you really cannot wake them up, because it must be such a strong response, and they're probably, a little hypotensive. They need fluids. You're not going to do it at home with the oral rehydration, but everything else I'm trying to manage at home, and sort of started like really during the pandemic, where we're like thinking a lot of those kids get better by the time they get to the ER anyway, and they get to the ER and they're just being watched and they're giving Pedialyte. Why expose them? And then I think we need to analyze our results and really see how safe it was, and just maybe have a little bit more faith in home management, like with other situations. But there's a lot of respect for FPIES in the allergy community. The ones of those of us who deal with the patients, those, if it's a bad reaction, it looks horrible. It's just it's scary. Kids are looking really unwell. So that's why, like, you have to have a plan, like backup too. Yeah.
Absolutely. I have two more questions for you. One being, are there any other disease processes that FPIES can sometimes be a precursor to? I haven't come across a whole lot of that, or any associations. And then I'll ask you my last question.
So that's a great question. So I'm not sure if it's a precursor or just a marker, because we know that kids that have FPIES, the infants that have FPIES, are likely to develop IgE-mediated food allergy. So FPIES is associated with the IgE-mediated food allergy. So it's a different story from atypical FPIES, right? It's now we're talking, okay, a child has FPIES to oat, but by the way, they can also have anaphylaxis to milk or peanut, so it just sort of stems to this common predisposition, common underlying mechanism, right, of the allergy. So the IgE-mediated food allergy. We also know that EOE is more common in children with FPIES, as well as asthma, and definitely atopic dermatitis. So, kids may start sort of, with the gastrointestinal symptoms, but over time, it's, it affects other systems. As far as whether FPIES can become something, or like the children with FPIES, will they have irritable bowel syndrome, or will they develop inflammatory bowel disease, like other inflammatory conditions?
Or celiac disease? That's a question that I get a lot too.
No, I that's not my experience, and maybe if somebody knows different, they should publish that so we know, but not not that we know of among those patients, and certainly there's more studying to do, but so far, at this stage, we really don't have this kind of a war. It seems like, it's the immaturity of the gut, something about the microbiota, like how it develops, and like this immune system that is, has this predisposition, like, to unusual, abnormal kind of, immune response, that it's like a perfect setup.
And my last question is, we've talked a lot about FPIES today, so much in such a short period of time. And I wanted to ask you what questions, or what's the biggest question that you get that we haven't covered today, or that you see as a big misnomer, whether that's from families or from allergists?
I think, there is definitely, among the allergy community, the pediatricians, there is a increased awareness of FPIES. I think what I really pay attention to is the introduction of foods. Like, do not delay the introduction of foods. And I think we don't have a consensus on the early introduction of egg and peanut. The guidelines. So, there's this table that we put together. So 5 years ago, we said, okay, delay introduction of egg and peanut, until a year old. And now we are saying, if you have a child at risk, definitely want to introduce peanut and egg earlier.
Mm-hmm.
And we also know that we're seeing more peanut and egg FPIES. At least it seems like we're seeing more. So there seems to be some, conflict, right? But I think we should say it loud and clear, like our studies suggest that FPIES from all of the foods affects 0.5% of children with in the US. Peanut alone is like between 2 and 4%. Okay.
Mm-hmm.
So conservative estimates like 2.2. And like, I think it's a little bit more than that. So, sort of weigh it, like whether you have FPIES versus, peanut anaphylaxis, when you can reduce your chances by 80% by early introduction. So to me,
Right.
If you have a baby that starts as FPIES but has significant eczema or strong
Mm-hmm.
family history of atopy or, food allergy in the parents or sibling, I really would say bite the bullet, of course, discuss with the patient, but really try to empower them to introduce peanut and egg because the stakes are high and still there's much lower risk of FPIES. And usually the good news about the FPIES is, right, like, that patients are not that exquisitely sensitive that like a drop of milk or, a lick of peanut is going to produce a reaction. It's usually a serving, like something
Right.
measurable. So even from that perspective, it's a better, I think it's in that regard, I think I would rather have FPIES to peanut than, anaphylactic peanut allergy. So yeah,
Thank you so much
not an easy answer, but the best I can give you.
That's a great answer. Thank you so much for sharing that and for coming on the show and sharing your expertise. God bless you for the work you're doing. I know a lot of our listeners are going to be very excited to hear this episode. So thank you so much.
Oh, it was my great pleasure. Anytime I feel like it's important to, to talk about FPIES, to make sure that parents know about it and that, really it's scary in the beginning, and it's definitely nerve wracking to try introduce the foods and after having an episode, but don't give up. It goes away and the child, will grow beautifully and will be healthy when they get older. So thanks for having me, Alice.
Oh, it is my pleasure.
That's the episode. Thanks so much for tuning in. Of course, I'm an allergist, but I'm not your allergist. So talk with your allergist about what you learned on this episode and visit us at foodallergyandyourkiddo.com where you can submit your family's questions. God bless you and God bless your family.